Yeah. Uh, Hi everyone. So today we are continuing our video lectures on the use of non-steroidal immunosuppressives in dermatology, and today we are going to discuss an important immunosuppressive, cyclophosphamide. Now, cyclophosphamide has been used for decades now in dermatology, predominantly as DCPs or Dexamethasone-Cyclophosphamide pulse therapy in management of pemphigus. And we'll be discussing this drug in the context of how it acts, its mechanism of action, its effect on the body, its use in various indications, and in the end, just stick to the end, and we'll be having a very short, not a short discussion on the use of cyclophosphamide as IV DCP pulse therapy and its use in pemphigus and its rationale for the use in pemphigus or lack thereof. Okay, so just stick to the end to the video, and we'll be having a short discussion on DCPs. Now, cyclophosphamide is derived from nitrogen mustard. Nitrogen mustard is a very toxic substance. It has been used previously in various wars, and it's a pharmacological ancestor of cyclophosphamide. So, cyclophosphamide is derived from nitrogen mustard. Now, the way cyclophosphamide acts is because of its alkylating nature. What it does, it introduces it introduces a lot of alkyl groups in the DNA, and that leads to cross-linking of DNA. Now, this cross-linking of DNA makes the DNA unsuitable for the regular functioning of cells, and this leads to damage to the cell. Subsequently, the DNA, because of direct damage to DNA, the cell undergoes apoptosis. Now remember that a cell needs DNA to survive, and if the DNA is damaged, it will not proliferate, it will not be able to carry out its routine function, and there will be control mechanisms which will lead to cell death. So any damage to DNA is what is known as mutation, and a mutated cell cannot be allowed to survive, and thus the cell dies. Now, cyclophosphamide acts independently to cell cycle stages. Previously, we have read about other immunosuppressives like methotrexate or azathioprine or mycophenolate mofetil, and they act on specific cell cycle stages, predominantly the S stage, where the cell is synthesizing a lot of macromolecules for division. Now, since DNA is present at all stages of cell cycle, the damage can occur at any stage, and therefore cyclophosphamide acts independently to cell cycle stages. It can act on all stages. All cells are affected, but the effect is more pronounced in proliferating cells. That is why cyclophosphamide is known as pan-cytotoxic. Pan means every, cyto is cell, and toxic. It is toxic to every cell. Okay, because all the cells in our body have DNA, and if the DNA gets damaged, it leads to the death of cell. All cells are affected because of cyclophosphamide. Coming to the pharmacology of the drug, bioavailability is around 75%. Peak plasma levels is about 1 to 2 hours. It takes around 1 to 2 hours for cyclophosphamide to attain its peak plasma level, and this is important when we'll be discussing the pulse regimen for cyclophosphamide. Protein binding is about 13%, and this is for cyclophosphamide. Now, what happens to cyclophosphamide when it enters our body is it is converted into various metabolites. Some of them are active, some of them are inactive. So, other metabolites are bound roughly 50% to plasma proteins, while cyclophosphamide individually is bound to about 13%. So, just remember that the pharmacological action of cyclophosphamide is also carried by the drug and its active metabolites, which are also responsible for the side effects of cyclophosphamide. So their binding is a bit different. Half-life is about 5 to 9 hours. It undergoes hepatic metabolism by cytochrome P450 enzyme, which is a very important enzyme we all know. We should know about 5 to 6 drugs that increase cytochrome P450 activity, or 5 to 6 drugs that decrease its activity and thus have an effect on cyclophosphamide metabolism and also its clinical efficacy and side effects. So we should remember that cytochrome P450 is responsible for metabolism of cyclophosphamide. Excretion is via kidneys. Less than 20% drug is excreted as cyclophosphamide. Other metabolites constitute about 30 to 60%, and the predominant metabolite excreted is carboxyphosphamide. Okay, so remember that CPA or cyclophosphamide is excreted as is less than 20% of the drug. 30 to 60% of the drug is excreted in the form of carboxyphosphamide and other metabolites. Dose for oral dose, it's roughly about 1 to 3 milligram per kg per day. For IV, it's about 0.5 to 1 gram per meter square. Okay, so these are two different dosing regimen. First one is for oral, and the second is for IV. Oral is 1 to 3 milligram per kg per day, and IV is 0.5 to 1 gram per meter square body surface area. Now, how does cyclophosphamide act? It's a cell cycle non-specific drug. That means it is not restricted to any particular stage of cell cycle. We have seen that previous immunosuppressives used to act on the S stage. Let me just write it again. They used to act on the S stage of the cell cycle, where synthesis of macromolecules required for cell division were taking place. But since DNA is present at all these cell cycle stages and it works by damaging the DNA, cyclophosphamide can act on any of the cell cycles. So it becomes a cell cycle non-specific drug. What it does is it forms covalent bonds with nucleophilic centers of DNA. And when these covalent bonds are formed, it leads to cross-linking and abnormal base formations in DNA. And when DNA has a lot of abnormal formations, it leads to cross linkages leading to DNA damage. And what DNA damage leads is known as mutations. And a mutated DNA cannot be allowed to survive. The cell cannot be allowed to proliferate. So when the DNA is mutated or damaged, it leads to activation of multiple apoptotic pathways leading to cell death. Okay, so just to recapitulate, covalent bonds with nucleophilic centers of DNA leading to cross-linking, abnormal base formation leading to direct DNA damage, leading to mutations, leading to apoptosis. So remember that the mechanism of action of cyclophosphamide is direct DNA damage. Okay. Now the action of cyclophosphamide is found to be a bit more on B cell as compared to T cell. Remember that cyclophosphamide pulses, monthly IV single day pulse, was initially given in patients of SLE, especially those with lupus nephritis, and led to good control. So we can remember that the activity on B cell is found to be more as compared to T cell. Additionally, the immunosuppressive efficacy of cyclophosphamide is found to be more on suppressor T cell as compared to helper T cell. And this is one of the theories given behind the increased incidence of lymphomas in prolonged use of cyclophosphamide. So in patients with different malignancies in which cyclophosphamide was given as a treatment, it has been reported to have increased incidence of lymphomas, and predominantly it is because of decreasing the activity of suppressor T cell. Now when we stop cyclophosphamide, the immunosuppressive action remains for the next 3 months. So it becomes a good viva question that after stopping the drug, the immunosuppressive action lasts for at least 3 months. Now, cyclophosphamide is essentially a prodrug. Okay, cyclophosphamide is a prodrug and it is converted in the liver to 4-hydroxycyclophosphamide. So CPA, cyclophosphamide using the cytochrome P450 system gets activated to form 4-hydroxy-CPA. Okay, all this, you could say, light orange area are the active metabolite. That is why it is known as the activation pathway. And the green one are the inactivation pathway. That means these molecules are not showing the immunosuppressive effects of cyclophosphamide. The effects are basically seen by 4-hydroxycyclophosphamide and aldophosphamide. See this reversible arrow? That means when cyclophosphamide gets converted into 4-hydroxycyclophosphamide, it exists in an equilibrium with aldophosphamide. After aldehyde dehydrogenase enzyme converts them into inactive metabolites, and these are excreted, and we have already discussed about carboxyphosphamide, one of the major excretory products for cyclophosphamide. Now these two are responsible predominantly for the effects of cyclophosphamide, and with beta elimination, aldophosphamide gets converted into phosphoramide mustard and acrolein. Now these are toxic metabolites. Phosphoramide mustard is responsible mainly for GI side effect, while acrolein is responsible mainly for genito-urinary side effects. We'll be discussing when we'll be discussing the side effect profile of cyclophosphamide. Just remember that these two are the toxic metabolites of cyclophosphamide, mainly phosphoramide mustard and acrolein. Okay. Now, indications for cyclophosphamide uses. Indications. Oh, just a second. Indications of cyclophosphamide. Okay. So, US FDA has approved indication for non-dermatological and dermatological uses. In skin, it is used only for mycosis fungoides and that to advanced stages of disease. So, we need to keep in mind that there is one indication for use of cyclophosphamide in skin, and that is advanced mycosis fungoides. Non-dermatological, like any other immunosuppressives, is lymphoma, leukemia, multiple myeloma, ovarian cancer, breast carcinoma, retinoblastoma. So we just need to remember that there is one indication in dermatology, and that is advanced mycosis fungoides disease. Now, all other indications are off-label as compared to FDA. And again, whenever we are remembering the indications, we just have to remember the headings. So in immunobullous disease, bullous pemphigoid, cicatricial pemphigoid, and pemphigus. But in Indian scenario, use of cyclophosphamide in pemphigus is extremely, you would say, it's one of the major uses of cyclophosphamide that we see in our training as residents and also in our practice. We use majorly in treatment of pemphigus vulgaris. Now, other immunobullous disorders like bullous pemphigoid and cicatricial pemphigoid are also indications. Now, vasculitis or vascular-related disease. So, predominantly, it has been used for venous granulomatosis. It has shown to be very efficacious in venous. Other vasculitides like Church-Strauss, HSP, and PAN, these are the other indications or other uses of cyclophosphamide. Neutrophilic dermatosis like Behçet's disease, erythema elevatum diatomum, and pyoderma gangrenosum. Now, just a short note that pyoderma gangrenosum responds very well to steroids. It's one of its diagnostic criteria. So, any immunosuppressive drug can be used in PG. Autoimmune connective tissue disorders. Now we know that SLE is an important indication for cyclophosphamide, and in patients who have lupus nephritis, they do benefit a lot from IV cyclophosphamide pulse. It's one of the initial indication of monthly IV cyclophosphamide pulse. One point to keep in mind is that in cicatricial pemphigoid, they have found that ocular mucosal involvement responds very well to cyclophosphamide. Okay, so just one point to remember. Now, other indications of use of cyclophosphamide are bullous drug eruptions like SJS, erythema multiforme major. Now, remember these are case-to-case basis, and there are only isolated case reports. So just remember these names: bullous drug eruptions, and additionally Langerhans cell histiocytosis. It has been used in Langerhans cells, even non-Langerhans cell histiocytosis like xanthoma disseminatum. So multicentric reticulohistiocytosis. So these are lesser known isolated indication of use of cyclophosphamide, predominantly because of its cytotoxic nature. Now, contraindication. Like always, hypersensitivity to the drug is an absolute contraindication. Also, hypersensitivity to the components of the formulation are also contraindicated. So, if your patient is hypersensitive to either cyclophosphamide or the constituents of the component, that means the base, preservatives, stabilizers, so you cannot use, of course, cyclophosphamide in those patients. None of the warnings have been listed on the box. And urinary flow obstruction. Now remember that acrolein, one of the toxic metabolite of cyclophosphamide and hydroxycyclophosphamide, is responsible for genito-urinary side effects. So if there's urinary outflow obstruction, it will be in contact with bladder mucosa for a longer duration, leading to increased chance of bladder carcinoma. Other warnings and precautions are infection. So, with all immunosuppressive drugs, we see that there can be a rise in opportunistic infections. So, that warning is same as any other immunosuppressive drugs. Malignancies, predominantly hemorrhagic cystitis and subsequent bladder carcinoma, most commonly transitional cell carcinoma of urinary bladder. So this malignancy is somewhat specific to cyclophosphamide, and we need to keep that in mind. And if you are asked about side effects of cyclophosphamide, you need to mention that in Viva. So nausea and vomiting are common side effects. They happen with with any other drug. Bladder fibrosis is used for long term, and if high dose cyclophosphamide is used, bone marrow suppressions, because it is cytotoxic, it will destroy all cells, more so the proliferating cells, and because of that, it can have a severe bone marrow suppression. It may interfere with normal wound healing. So just you have to remember just have to remember the headings. So infections, malignancies, GI, bladder, hematological and miscellaneous. And in this you just have to remember hemorrhagic cystitis possibly preceding bladder cancer. So you just remember that this is important. Now, older pregnancy category was category D, but the newer category states it as contraindicated. It's a cytotoxic drug. It will kill all drugs. It will kill all cells. So the newer rating is absolutely contraindicated in pregnancy. Additional side effects include genito-urinary, starting with bladder fibrosis, necrosis of bladder epithelium, contractures, increased vesicoureteral refluxes, urgency. Now, hematuria is important because hematuria and hemorrhagic cystitis are somewhat a precursor markers for malignancy. So, if any of your patients on cyclophosphamide therapy develops hematuria or hemorrhagic cystitis, you just have to remember that you have to be very, very careful in monitoring the urinary parameters for that patient. Keep them in long-term follow-up for development of any transitional cell carcinoma in the urinary bladder, and if possible, switch them to other immunosuppressive drugs. Hemorrhagic cystitis is seen in 5 to 41%. It is dose-related and caused, as we have already mentioned, by acrolein toxic metabolite of cyclophosphamide. Now, carcinogenesis, we have to be a bit more, our threshold of suspicion should be a bit lower for bladder carcinoma, leukemias and lymphomas, and squamous cell carcinoma. So remember that suppressive T cell function is decreased, and this is one theory given why we have theoretical increased risk of leukemia and lymphoma or squamous cell carcinoma when the patient is taking a cyclophosphamide. Remember that it is because of high dose or a longer duration of treatment, and predominantly these malignancies have been seen in patients who have receiving cyclophosphamide for other cancers. Remember that non-dermatological indication for cyclophosphamide are different cancers like leukemias, lymphomas, non-Hodgkin lymphomas, multiple myelomas, and for those patients the dose of cyclophosphamide is majorly towards the higher side, and they have been reported with this kind of malignancies. But bladder carcinoma is specific for cyclophosphamide, so we need to keep our eyes open for this. GI side effects include anorexia, stomatitis, hepatotoxicity with high doses, hemorrhagic colitis, and nausea, vomiting, diarrhea are the commonest side effects seen into about 70% of patients. And we are discussing a bit more in detail, we'll tell you how it can be treated. Now, hematological side effects include anemia. Now, leukopenia is a common blood-based side effect of cyclophosphamide. Remember that all the drugs, majorly proliferating cells, are getting damaged. So, all cells and the leukocytes and lymphocytes are much more proliferating cells. So, they are much more prone to DNA damage by cyclophosphamide. and it starts by 5th to 6th day and gradually recovers if the dose is lower or it's not that high and the duration of treatment of cyclophosphamide is not prolonged. It might start to recover after stopping drugs roughly around 15 to 20 days. With higher doses, thrombocytopenia have been reported. So remember that the most common blood-based side effect is leukopenia. Reproductive side effects include amenorrhea, azoospermia, and ovarian failure. We'll discuss that in subsequent slides. There are somewhat dose-based cutoffs for cyclophosphamide. So after those cutoffs, the risk of azoospermia, amenorrhea is significant. So we need to remember those cutoffs so we can either counsel the patient or we can make our monitoring much more rigorous so that these side effects can be looked before they actually have a significant impact on the daily life. Now remember that in my opinion, cyclophosphamide should be used in those patients whose families are complete. Now by complete family we mean that they have if they have two children, the younger one should be more than 5 years of age, healthy, not an issue health wise, and they should know that this drug can have significant impact on their fertility, especially in a country like India. You need to be much more overt with this drug and discuss a lot with your patient, and this becomes a very good drug for patients whose families are complete because it has significant impact on fertility. As per skin, alopecia like anagen effluvium can be seen in 5 to 30% and it's usually reversible when the doses are stopped. Pigmentation of skin and nails. Now skin, nails, teeth, even all mucosas like oral mucosa and esophageal mucosal pigmentation have been described. One thing to remember is that pigmentation of the teeth is irreversible. So this is known as permanent pigmented band of teeth. And this is seen as mainly in patients with long-term cyclophosphamide use. But remember that the teeth pigmentation is irreversible. And SJ syndrome has also been reported with cyclophosphamide. In genito-urinary side effect, this is one of the major organ which is affected by cyclophosphamide use, and we have to be very careful, and our urine analysis should be much more rigorous while the patient is taking cyclophosphamide. Now, hemorrhagic cystitis is seen in 5 to 41% of patients. It is majorly because of acrolein toxic metabolite or cyclophosphamide. Now, what other factors that we can say that smoking increases the chances of you developing bladder carcinoma. Smoking is an independent risk factor for bladder carcinoma, so this also increases. And acrolein, even in low doses and shorter duration, can lead to bladder carcinoma. Can lead to hemorrhagic cystitis. So, if your patient is taking DCPs or in fact oral cyclophosphamide for pemphigus or for any other indication, make sure to have a normal urine routine microscopy before you start and be very rigorous. Roughly monitoring guidelines say about every 2-week urine examination, and keep on asking about clinical symptoms of any blood in urine, brown urine, or even frank blood in during micturition. Now Mesna is a protective compound. What Mesna does is, I've written the full name here, it's sodium 2-mercaptoethane sulfonate. It binds to acrolein and enhances its excretion. Okay, let me just write it again. Mesna binds with acrolein and increases the excretion of this compound. Now, how much Mesna to give, whether to give it or not, is decided by the person who is treating the patient. It's a physician-based discussion, physician-based decision. Various reports or various articles in literature say that Mesna dose should be equal to cyclophosphamide. I've read articles in which it is divided into 5 doses given over 24-hour period. On the day cyclophosphamide IV is given during pulse. Some people say 75% of dose of cyclophosphamide, some say 50%. The range varies from 20 to 100% of Mesna divided. If it is supposed to be given IV only, oral, or IV or oral both, I have seen multiple articles regarding different regimens. Some article mentions you give 20% IV with just after just after cyclophosphamide use, and the rest 60 to 80% is given orally over the next 24 hours. So multiple regimens exist. It's better to go through each and individual recommendation so that you can either answer properly during Viva if a question is asked whether to give Mesna or not. It's always good to give Mesna and combine cyclophosphamide therapy with Mesna administration because it acts as a good bladder protective agent because of increased excretion of acrolein with after binding to Mesna. But remember the most important point to prevent genito-urinary side effect is to ensure that your patient is hydrated. Being hydrated is one of the most important factors. If the patient is on oral cyclophosphamide, counsel them to drink a lot of water so that it is rapidly excreted from the urinary tract and urinary bladder. And if you're giving IV cyclophosphamide pulse, it's a good idea to hydrate with 1 unit normal saline before giving the pulse. Okay, so make sure that patient understands that dehydration could be detrimental for them. So avoid activities which might lead to dehydration over prolonged duration of time, leading to concentration of urine and subsequently concentrated acrolein in the urinary bladder. And this will help to prevent hemorrhagic cystitis. Now, bladder malignancy. Remember that hemorrhagic cystitis can be seen as a precursor to bladder malignancy, and the most common bladder malignancy that has been implicated is transitional cell carcinoma. Now, it is duration related. That means the longer the treatment with cyclophosphamide, the more chance is to have a bladder malignancy, and it is usually preceded by non-glomerular hematuria. So remember, if your patient is taking cyclophosphamide, keep on asking them whether there is any change in urine and to get urine routine microscopy to look for frank RBCs or cast in urine. Surveillance, and this can lag up to 15 years. That means even after stopping cyclophosphamide, there is a chance of your patient developing bladder malignancy, and that chance can be seen in as long as 15 years after therapy. Now, this is an important factor which goes against the use of DCP in Pemphigus because there has been, I think, no long-term side effect profile of patients who have taken high-dose cyclophosphamide for Pemphigus and whether they develop any bladder malignancies or any bladder disorders many years after the treatment has been stopped. Now, these are the dose related or the dose cutoffs for various side effects, and this has been described in various literature. 6 to 10 gram has been linked with azoospermia, and I remember during my residency, greater than 9 gram is associated with universal azoospermia. That means in all patients, if they achieve a dose of more than 9 gram, azoospermia is seen. Amenorrhea is seen in females, and its chances of developing amenorrhea increases with the age of the female. It has been said that if the female is more than 40 years of age, chances of amenorrhea is very much high. Patient will develop amenorrhea, and that amenorrhea can in fact be irreversible. It might not improve or it might not revert back to baseline when the doses are stopped. This is important. So remember that the patient has to be counseled and to consider cyclophosphamide on patient in whose families are complete. And this important side effect has to be discussed with your patient before starting even oral or IV cyclophosphamide. Now, some of the articles mention 18 gram to cause reversible azoospermia, but this more than 9 gram is a good dose to remember and answer in Viva. 25 to 80 grams of cumulative dose has increased propensity for various malignancies, and 2.8 to 100 gram range has been associated with hemorrhagic cystitis. So out of this, I think more than 9 gram is one number that you should remember, and also remember that increased age is very important risk factors for developing amenorrhea in female patients. Other adverse effects like malignancies we have discussed in detail. These are malignancies other than genitourinary malignancies. Cancers like non-Hodgkin lymphomas, squamous cell carcinoma, and leukemia are increased. We have already discussed that one of the theory is suppression of suppressor T cell activity. And these have been reported predominantly in transplant patients in which high dose cyclophosphamide is used for a prolonged duration. So these are independent risk factors, but remember the same thing can happen when you're treating patient with pemphigus. So just keep a lookout on cumulative doses and have a good clinical suspicion on follow-up visits. Now, other side effects like gastrointestinal side effects are the most common adverse events in patients, seen in about 70 to 90% of cases. It can be treated with giving ondansetron roughly half an hour to 2 hours before the administration of cyclophosphamide pulse along with good hydration. If the patient is on oral cyclophosphamide, give half an hour to 1 hour before. Usually 4 grams is the starting dose. Combine cyclophosphamide with dexamethasone as we do in DCPs. It's a good agent, a good regimen to counteract GI side effects. And aprepitant is an FDA approved agent to counteract nausea related to chemotherapeutic drugs. So aprepitant helps. So you can use either all three of them or one of them or two of them in combination to manage if there are any GI side effects. Now remember that phosphoramide mustard is the toxic metabolite responsible for this GI side effect. So cyclophosphamide gets converted subsequently into phosphoramide mustard and acrolein is responsible for genitourinary side effects, and phosphoramide mustard is related to gastrointestinal side effects. Okay. Now, leukopenia is one of the most important hematological side effect of cyclophosphamide. It starts from the 6th day and nadir is reached in 9 to 12 days. So, what nadir means, whenever there is a wave or there is a graph, the highest point is zenith, the lowest point is nadir. That means the cell count keep on decreasing and it reaches the lowest point in about 9 to 12 days, and as per 15 days they start to recover. So that is more in the context of DCPs, that on the day you give DCP, it starts to decrease from 6th day. It reaches its lowest value in 9 to 12 days, and the counts start to improve in 15 days. So it's see, in literature it has been described that you can give cyclophosphamide 500 milligram interval pulse. That means a pulse between two monthly pulses. So if you give it at 2-week interval, it might lead to increased chances of infection and sepsis because your leukocyte counts are just recovering. So just make sure that it is restricted to certain specific indications. Okay. Amenorrhea seen in 30 to 60% of female patients. Additional side effects include premature ovarian failure and ovarian fibrosis on long-term or high doses of use. Azoospermia is a significant side effect we have discussed a little bit in previous slides. Administration of testosterone helps. Okay, so administrating testosterone helps to prevent azoospermia caused due to cyclophosphamide. So another good idea would be to counsel the patient if they can freeze their sperms or ova. It's a better if the facility is available and the patient is affording, and cyclophosphamide is the only drug you want to use, there are no other drugs because of contraindications, have a discussion whether they would like to freeze their gametes so that pregnancy can be achieved further if required. Anagen effluvium with cyclophosphamide is seen in 5 to 30% of patients. Permanent pigmented dental band we have discussed, nail pigmentation, tongue pigmentation, and generalized hyperpigmentation too. Remember that dental band is irreversible. So that has, if you see the patient, if you see any patient developing dental pigmentation, counsel them that this might not go away. Now, pulmonary side effects include fibrosis of lung and interstitial pneumonia. And remember that the chances of infections increases with cyclophosphamide, so you need to ask about fever, cough, and if possible auscultate the patient on follow-up visit. This side effects are important while the patient is taking cyclophosphamide. Now remember that cytochrome P450 systems are responsible for metabolism of uh, cyclophosphamide. So drugs that reduces cyclophosphamide levels include dexamethasone, ondansetron. We have read about that, how they can help to managing GI side effects. Rifampin. So these drugs increase the metabolism of cyclophosphamide, and we know that this cytochrome P450 enzyme is there in liver, and cyclophosphamide undergoes hepatic metabolism. So drugs that may reduce these levels are important for us to remember by. Even prednisone also. These are drugs that we routinely use in our daily practice. Drugs that may increase cyclophosphamide levels include allopurinol, an anti-gout agent. Remember, this has a good interaction with azathioprine. Remember, or if you don't remember, go back to the video and see again. Okay. Ciprofloxacin, cimetidine, fluconazole. None. These are those drugs that we may routinely use in our patients. So we need to remember these few drugs that may increase cyclophosphamide levels and thus increase side effects or adverse effects of the drug. Drugs that potentiate myelosuppressive nature or immunosuppressive nature of cyclophosphamide or its carcinogenic side effects. So antiretroviral agents like zidovudine and cytotoxic agents like chlorambucil can increase the myelosuppressive side effects of cyclophosphamide or the immunosuppression provided by cyclophosphamide. Remember that chlorambucil, cyclophosphamide, all of these are included in the larger gamut of cytotoxic agents, and this can substantially increase the adverse event of cyclophosphamide. Other drug interactions are seen with halothane, nitrosoxide, succinylcholine. This is just to read once so that you may remember or not. Digoxin, because cyclophosphamide may decrease the absorption of this inotropic agent. So if your patient is taking digoxin for management of cardiac arrhythmias, make sure that the cardiologists know that cyclophosphamide is a drug that you are going to give it to them, or it's better not to use cyclophosphamide and consider any other immunosuppressive drug. Now, in additional points regarding vaccines, remember that with any other immunosuppressive drugs, if you are using live vaccine, you need to be careful, or it can lead to an increased disseminated infection because of the particles or the subdued pathogen in the vaccines. So it has been advised to give vaccines. Let's say you start cyclophosphamide here. It's good idea to give vaccines either more than 2 weeks prior of starting cyclophosphamide or give it after 3 months of stopping cyclophosphamide. A good idea would be to remember that the immunosuppressive effect lasts for 3 months after stopping the drug. So 3 months becomes a good cutoff. Okay. Other vaccines like killed vaccine should decrease immunological response, decrease seroconversion, like we have seen previously in using all other non-steroidal immunosuppressive drugs. So with killed vaccine there can be lower propensity of seroconversion. That means development of good amount of active antibodies. Now with warfarin, a concomitant cyclophosphamide use can lead to an increased anticoagulant effect. So if your patient is on warfarin for any cardiac issues or maybe stroke or any other prevention of thromboembolic events, using with cyclophosphamide can lead to an increased anticoagulant effect, and patient might have inadvertent bleeding on any of the side effects of warfarin. Now, cyclophosphamide and Mesna. So, we have finished majorly the salient points of cyclophosphamide, and we'll just discuss some fewer additional points of cyclophosphamide. Now, we'll discuss the use of Mesna with cyclophosphamide. Mesna is protective for bladder adverse effect because of binding to acrolein, leading to increased excretion. And we know that acrolein is responsible for bladder adverse events. So Mesna is used when bladder adverse events are supposed to be prevented. Now the dose ranges to from 20 to 70% of IV cyclophosphamide use, so a dose. So whatever the dose be, let's say X is the X milligram, or let's say X gram is the dose of cyclophosphamide which you are giving per day. Either 20% to 70% of Mesna is supposed to be given. But remember, the patient has to be coupled with a lot of hydration. Counsel the patient to drink a lot of water. Even if you're giving only oral cyclophosphamide, no IV cyclophosphamide, you have to counsel them to drink a lot of water. Okay. If you want to give Mesna with both of routes of administration, 20% of the dose is given IV with cyclophosphamide IV pulse, and the rest 60 to 80% is given oral over the next 24 hours. Okay. Remember, it's case to case basis to give or not to give, but it is always beneficial to give. Plus, you have to couple with hydration. This is very important. Hydration is important. So whenever you are planning a patient for long-term or even a short-term cyclophosphamide use, whether oral or IV, hydration is much more important, and you have to couple it with Mesna to prevent bladder adverse events. Clear? Now, just to recapitulate the effect of cyclophosphamide on fertility, it may cause irreversible amenorrhea, and the chances increases with dose of cyclophosphamide use and also the age of patient. Remember that women more than the age of 40 years are significantly at risk of developing irreversible amenorrhea. Okay, azoospermia seen in 50 to 90% of male patients. So this factor has to be discussed with your patient. It's always a good idea to get a proper detailed consent form and get those signed by it. The consent form should focus more on first the benefit the patient will have with the regimen. Tell them that it is an non-FDA approved indication that we are using. If you are using it for anything else than advanced mycosis fungoides, and remember to discuss the issue of fertility with the patient. It becomes a huge important aspect in our country, so this has to be discussed. Also discuss whether it's possible for them to freeze sperms and ova. So it's better if this can be done so that subsequent pregnancies can be taken care of. So in the current day and age, people are getting married later, and they tend to conceive children later at a later stage. So it's becoming a very common practice to freeze sperm and ova, which can be used at a later stage for pregnancy. So if the patients are open to it and you want to specially use cyclophosphamide in those patients, it's better to discuss at least whether they will be considering to freeze sperms and ova, so that the issue of infertility with cyclophosphamide use is curtailed. Now, monitoring on initial evaluation, a careful history and physical examination is a must. Survey for any other drugs that the patient might be taking which may impact cyclophosphamide metabolism. CBC with differential cell count and platelet cell count is important. Basic serum chemistry profile like LFTs and KFTs are important. Urine analysis to look for any bladder abnormalities or urine abnormalities before starting treatment. Serum pregnancy test, remember that it is older category B, but newer category says as contraindicated. So it's a good idea to have UPT. Newer category is contraindicated. Now, ongoing laboratory monitoring. CBC with differential or platelet count perform weekly for 2 to 3 months, and then to bi-weekly after 2 to 3 months, and then monthly when the dose is stable and you are not increasing the dose. Remember that you have to either decrease the dose or discontinue therapy when WBC counts are persistently below 3500 per millimeter cube, or platelet counts are below 1 lakh per millimeter cube. So remember that this becomes an important blood parameter to consider stopping the drug or if that is the only drug which is approved or suitable for the patient, manage on a decreased dose. Urine analysis is an important aspect of monitoring because of increased chances of bladder malignancies and hemorrhagic cystitis and also non-glomerular hematuria. Perform weekly for 2 to 3 months, then transition to bi-weekly after 2 to 3 months, then eventually to monthly with stable dose. If there are any red blood cells in urine, you decrease or discontinue the dose, and always it's a good idea to include a urologist so that they can do all the imaging and scopy techniques to find out if there is any bladder abnormality. And remember that these are somewhat stringent monitoring guidelines, and maybe in daily practice we are not able to follow these guidelines properly. That should not mean that you don't do it in a regular intervals, and make sure you read the reports fully and find out if there's any ongoing abnormality or any change of levels of any of these parameters, so that you may either counsel the patient or decrease the dose or stop the treatment. LFTs are performed monthly, and then after 3 to 6 months, the frequency of testing may be reduced to quarterly examination. And follow-up examination should be done for lymphadenopathy. Remember that the chances of lymphomas are increased, so it's a good idea to do for management of lymphadenopathy. And pap smear for women, because associated ureteric malignancies have also been reported. Now with this, we conclude our basic discussion regarding the drug cyclophosphamide, its indications, how it acts, what are the major side effects of these drugs, and what all we have to look for while giving a patient a prolonged regimen with cyclophosphamide. So that is important. Now we'll discuss just shortly in brief the DCP therapy in cyclophosphamide. DCP is Dexamethasone-Cyclophosphamide pulse therapy in Pemphigus. Before we start any discussion, it's a kind of a disclaimer that the institute in which I did my residency would give DCP left, right and center in patient of Pemphigus, and I have seen it work very tremendously well in Pemphigus with good control of disease. I've yet to follow any patients for long-term side effects of DCP, but in instances where Pemphigus has shown significant inflammatory activity not being controlled by regular immunosuppressive drugs, DCP did come to rescue. But there have been good points made in favor of or refuting DCP. So we'll just discuss that in very brief. Maybe in future I'll make a detailed video with all the references so that the viewer can have a good idea about whether to consider DCP in control of Pemphigus disease or not. Okay. So DCP therapy in Pemphigus. Now, initially, cyclophosphamide therapy was started with IV cyclophosphamide therapy. This was a one-day pulse given for control of lupus nephritis. Now, what exactly is pulse? That's a good viva question. Pulse is the administration of suprapharmacological doses or drugs in an intermittent manner. Okay, so it's a suprapharmacological doses of drug in an intermittent manner, which is roughly about 1 to 3 days a month. So if you are giving only cyclophosphamide, it is 1 day a month. If it is combined with dexamethasone and DCP, it becomes over the course of 3 days in a month. Now, lupus nephritis protocol was developed for control of lupus nephritis using cyclophosphamide 1 day a month pulse, and a modification of this protocol was done by Dr. Pasricha sir, one of the greatest doyens of dermatology, in the year 1984. So this could be a good viva question. So in the year 1984, the protocol for lupus nephritis was modified for its use in Pemphigus. Okay. The dose of dexamethasone used was arbitrarily chosen, and it's a fixed regimen to be used in all patients. There are multiple modifications of DCP, and I would request anyone who would like to read about it is to go and do a good PubMed search, and you will find multiple modifications in DCP protocol. But the standard protocol we'll be discussing in subsequent slides. And IV, the DCP pulses. What we mean by DCP pulses is only IV pulses over the course of 3 days, in which day 1, 2 and 3 is Dexa, and the middle day, the second day, cyclophosphamide, we combine it with Dexa. So this is DCP. So it's Dexa on day 1, Dexa cyclophosphamide on day 2, and Dexa again only on day 3. Okay. Additionally, it has been said that oral cyclophosphamide is also continued when DCPs are being given, and the use of both oral and IV cyclophosphamide leads to excessive immunosuppression. This excessive immunosuppression is the one which helps in counteracting the inflammatory activity or the autoimmune activity of pemphigus, and that is how we are able to control a disease with intense autoimmune activity. However, this excessive immunosuppression is what leads to increased side effects, mainly infection and sepsis, and this can be taken as a point against the use of DCP in pemphigus. Remember that pre-DCP mortality for pemphigus vulgaris was around 70%, and with the use of conventional oral corticosteroid, the mortality used to reduce till about 20 to 50%. Okay, so mortality before DCP in pemphigus was 70%. It went down to 20 to 50% with the use of oral corticosteroids. But after the use of DCP, the mortality rate has been around or less than 5%. There are articles that mention 6% also as mortality rate, but majorly the mortality rate has been less than 5% after DCP, after the introduction of DCP for the treatment of pemphigus. Now, when DCP was introduced, a majorly strong statements for DCP was made, saying that it's cure for pemphigus, and now the pemphigus is much more curable disease because DCP effectively stops the activity of pemphigus. Now remember that such kind of extravagant claims require excessively immaculate evidences. Strong evidences are unfortunately still lacking whether DCP is an end all cure for pemphigus, and whether we can actually say that pemphigus is now a completely curable disease after the advent of DCP. But in my opinion, it's better to keep DCP as a last resort when the inflammatory activities are not being controlled, especially in the current current environment or current stage where we have a lot of better drugs to manage in pemphigus. It could be rituximab, even IVIG, and these kind of drugs significantly manage pemphigus even in the direst of situations. So maybe DCP can be kept as a last resort, and you should always remember that whenever new drugs keep on getting introduced in the market, it's very easy to forget older drugs, but we need to remember them so that we can have multiple and more options for treating our patients. Okay. Now the phases of pemphigus pulse therapy. The phases of pemphigus, this is an important question. It's an important viva question even at undergraduate level, and this is one question which was asked by our faculties during my undergraduation and even in post-graduation. So there are essentially 4 phases of DCP pulses. Phase 1 is the phase in which the lesions of pemphigus are present. The rest all phases the lesions are not there. In phase 1, DCP is given along with oral cyclophosphamide. Remember that using oral and IV leads to increased immunosuppression, and it's a good idea maybe not to give oral cyclophosphamide when IV DCP pulse are being given. But essentially the DCP regimen for pemphigus includes use of oral and IV cyclophosphamide both. Okay, so in phase 1, the lesions are present, DCP is given, and oral 50 mg cyclophosphamide every day is also given. And the number of pulses are once a month till no new lesion of pemphigus starts to come. Okay. In phase 2, the lesions have stopped coming. DCP is still continued for the next 9 months, Originally, the pulse therapy was for 6 months. It has been extended to 9 months, and oral cyclophosphamide is also continued. In phase 3, the lesions are still absent, but now the DCP is stopped. We don't give monthly DCPs in phase 3, only the oral cyclophosphamide is continued, and this is continued for the next 9 months. Original therapy was for 12 months, it has been reduced to 9 months. So, the number of months in phase 2 and phase 3 remains same as 18. Initially, it was 6 months for phase 2, 12 months for phase 3, but now it is 9 months for both of the phases. There is one modification of DCP in which it is said that not to give oral cyclophosphamide in phase 3, but to continue with only DCP without the use of oral cyclophosphamide in phase 3. So, this modification gives DCP monthly for additional 9 months, but the oral cyclophosphamide is stopped. In phase 4, no DCP is given, no oral cyclophosphamide is given, and follow-up annually is done for the next 10 years to look for the majorly the disease activity of pemphigus and the associated long-term side effects of cyclophosphamide. So I hope that now we are clear about different phases. Phase 1, lesions are present, both of them have been given till no new lesions develop. Phase 2, the lesions are absent and both of them are given for 9 months. Phase 3, lesions is absent, DCP is stopped and oral is continued for 9 months. Phase 4, both of them are stopped and follow up once a year for the next 10 years at least. The follow up can be more than that. Remember that certain side effects like bladder carcinomas can be seen after a lag period of 15 years too. So it's a good idea to keep them under follow up after 10 years. Now this is the dosing regimen for the 3-day DCP pulses. Day 1 includes dexamethasone 100 mg and 500 ml of dextrose IV over the course of 2 hours. Day 2 is dexamethasone 100 mg plus 500 mg of cyclophosphamide in 500 ml of dextrose over 2 hours. Now remember that if only cyclophosphamide is given, sometimes the dose is increased to 750 to as high as 1000 mg when you are giving cyclophosphamide only for 1 day. So I'm talking here about IV cyclophosphamide pulse, not DCP, but IV cyclophosphamide pulse, 750 to 100 mg single day pulse once a month. But when cyclophosphamide is combined with with dexamethasone, the dose is reduced to 500 mg. Okay. And on day 3, the day 1 regimen is repeated with dexamethasone 100 mg in half a liter of 5% dextrose over the course of 2 hours. Now there have been modifications in which people have said that over the next 5 to 6 hours infusion can be tried, but remember the half-life is about 1 to 2, sorry, the peak plasma level is achieved in 1 to 2 hours, so it's better to give over 2 hours. Okay. Now just in the subsequent two or three slides, we'll discuss what are the advantages and disadvantages of using DCP. Now, DCP leads to a quicker arrest of disease activity in pemphigus. I've seen patients responding with even a single or the first pulse of DCP, and there is subsequent decrease or even arrest of any new lesion development. It has shown better efficacies as compared to other immunosuppressive drugs, but remember that good controlled RCTs are still lacking to show significant proof or significant evidence for the use of DCPs in pemphigus. So the use, whether you would like to use DCPs in your patient or not, is an entirely personal decision which is taken after discussing everything with the patient. It also decreases the side effects of long-term steroids. Remember that pulses are given to decrease these long-term side effects. The requirement of the patient of pemphigus for long-term steroids is reduced, thereby reducing the associated side effects. Reduced mortality. Remember that before DCP it was 70%, with conventional steroids 50 to 20%, and after DCP it has been reported to be equal to or less than 5%. It is cheaper. Okay, it is cheaper because Dexa is cheap. Cyclophosphamide is cheap. It can be given in daycare. You don't require long-term admissions. and the overall cost of therapy is less. Roughly one pulse would cost the patient less than 1,000 rupees. If we are discussing only the cost of drugs, we'll discuss other costs in the disadvantages section. It is better tolerated by the patient, and most important, it works. It is shown to significantly reduce disease activity. It has shown to reduce disease activity in patients of pemphigus who are not being controlled by other drugs. So remember that DCP is still a good viable option to treat patients of pemphigus, but remember it has its own serious adverse effects, and it depends entirely on, number one, the expertise of the patient, of the physician who is administering DCPs, and how much the patient is able to understand the treatment protocol and the associated side effects. So remember, for any drug you have to discuss with your patient and regarding all these side effects, and then make a conscious decision whether to use DCPs for controlling the disease activity in pemphigus. Now, what are the associated controversies? Now, these are the all major disadvantages or all major points against the use of DCPs. Okay, the DEXA dose chosen was arbitrary. That means there is no pharmacological evidence of using that dose of DEXA. There is no pharmacological evidence of combining DEXA with cyclophosphamide. We just know, we have discussed in previous slides that dexamethasone decreases the doses of cyclophosphamide, and therefore there is a reported interaction between DEXA and cyclophosphamide. So we need to keep in mind that we are combining two different drugs which are known to interact, and especially the dose of DEXA for pulses. Even for only dexamethasone pulses, only DPs, the dose was chosen as arbitrary. There was no per se a pharmacological evidence. DEXA as a steroid was chosen because of its cheap nature. We know that in our country, in India, it is good to choose uh, cheaper drugs. So DEXA was chosen majorly because it was cheap and it did the work. Now, the use of IV and oral cyclophosphamide during DCPs have been shown to have excessive immunosuppression, which leads to increased chances of infection and sepsis, and patient might die because of the associated sepsis or side effect. Remember that pemphigus is a disease in which the superior protective layer of skin is removed, it's not functioning properly, and skin is a very important site of acquiring infections, predominantly hospital acquired infections or any commensal infections. So we need to remember that giving DCPs with oral cyclophosphamide may lead to increased immunosuppression, increased chances of infection, increased sepsis, and increased chances of mortality. Daily cyclophosphamide. Now, this has been a good controversial point whether to give daily cyclophosphamide orally while the patient is receiving DCP. We have already discussed previously that in phase 3 of DCP, the phase 3 means that no DCP is given, only oral cyclophosphamide is continued. But there have been modification in which DCP is given and oral drug is stopped. So whether oral drugs should be combined with IV cyclophosphamide, that remains a controversy. The original protocol does ask for oral and IV cyclophosphamide used together, but it's better to avoid oral drugs so that we may have less dose related side effects of cyclophosphamide. Now, is it really cheaper? Now, we know that rituximab biosimilars have been available to us for a prolonged duration now. It can be easily acquired. The cost is around 36 to 40,000 depending on what institute or what brand you're getting and where you're working. Remember that DCP is cheaper when you are only taking into account the drugs or the cost of the drugs that you are giving. Of course, rituximab is expensive, but remember, especially in private practice where the patient has to pay for each injection, each syringes, each IV fluid, and a daycare admission can cost them as high as 5,000 to 20,000 depending on the hospital you're working in. Giving monthly doses with 3-day hospital admissions, along with oral cyclophosphamide administration, and taking 3 working days out of a patient's life might lead to more cost to the patient. The cost benefit analysis has not particularly shown it to be much better when these factors are also taken into account. Remember that cyclophosphamide pulses, or pulses for that matter, are given on 28-day interval. So it can easily land up in a working weekday, and patient will have to, if they are working or maybe sole breadwinner of the for the family, you'll have to stop working for 3 days every month. So this might have an increased financial impact, and DCP might not be cheaper in those patients, and it will be a better idea to give rituximab, which may be cheaper in the long run. It leads to a decreased hospital stay, and as per the latest protocol, rituximab might be repeated at 9-month interval, and even that becomes a very cheaper regimen as compared to monthly DCPs. A good idea, in my opinion, would be to give DCP control activity, and when the patient is significantly stable, give rituximab for a uh, prolonged control of disease. But make sure that these kind of cost analysis are discussed with the patient. Remember that DCP might be cheaper when only the cost of drugs are considered, and monthly 1,000-1,500 will seem nothing to the patient, but over the long run it might be the more expensive option when rituximab is taken into account. Remember that higher doses and prolonged usage can lead to gonadal failure, azoospermia, amenorrhea, ovarian fibrosis, and premature ovarian failure. And in a country so obsessed with population, I mean, we are going to surpass China in terms of population. Somehow the importance of fertility is significant in a patient's mind, so this needs to be discussed, and it becomes a very significant adverse event. So this becomes a major adverse event for you to discuss with your patient, and whether it is beneficial to give cyclophosphamide to them or not. Malignancies have been reported, and there is a huge latent period. It can be as high as 15 years after the therapy is stopped. So remember that malignancies are significantly associated with prolonged use of cyclophosphamide or high dose use of cyclophosphamide. So it's a better idea to not give DCPs and consider other options like rituximab. Better drugs, we have already discussed that rituximab is available, IVIG is a good option, but these are all costly drugs, and these are usually and easily available in a government setup, and that makes it very preferable for treatment of pemphigus. Okay, and if the patient has a below poverty line card, even the government supplies rituximab for their treatment. So we have better drugs available. We have drugs which have lower side effects, lesser manageable side effects as compared to cyclophosphamide. It's a good idea to consider that. And as we have discussed in the last slide, cyclophosphamide can be kept as a last resort for treating pemphigus. Query cure. So as we have discussed in last slide, that when DCP was formulated, it was touted as a cure for pemphigus, that pemphigus as a disease will not exist because of DCP now. Remember that this kind of extravagant claim has to be backed by good evidence, and that evidence is still lacking. There have been no good, as far as I have done a very preliminary superficial search regarding any RCTs, well controlled RCTs, blinded RCTs done to see the efficacy of DCPs in control of pemphigus. They are still lacking. Maybe in future we'll get a better understanding of this drug, or better understanding of the DCP regimen per se in pemphigus, and we'll be able to make better decision. But remember that cyclophosphamide, being a pan-cytotoxic drug, has its own side effects, and we need to keep that in mind when we are using in our patients. So with that, we have just discussed briefly regarding the use of cyclophosphamide in pemphigus. Other things that you would read is, I think I'll just include links to each of these articles. One is that British Association of Dermatologists Guidelines for Management of Pemphigus, which came in 2017. It included DCP. It discussed DCP. It may not agree with giving pulses, but it did agree that it led to good control of disease with decreased mortality but associated side effects. It's a good idea to go through those guidelines, the BGD guidelines for control of pemphigus, if you want to know about DCPs and also other options available to manage pemphigus vulgaris. If you want to know the advantages of pulse therapy in pemphigus, this is a good article by Abraham A. regarding pulse therapy in pemphigus ready reckoner. It will very briefly tell you what DCP pulse is and what are the advantages. Contrary to that, pulse therapy for pemphigus, the burden of proof, is a good article by Singh S. in which they highlight various controversies and disadvantages of DCP therapy. And if you would like to know more about negatives of DCP, this becomes a very good idea, along with multiple articles which discuss the advantages and the disadvantages, the rationale or the lack thereof in treatment of pemphigus vulgaris with DCP. I urge that just a little bit of literature search will lead to a lot of articles, so you can go and find multiple points in favor of the argument or against the argument, so you'll be able to have a good understanding of the use of DCP in pemphigus. Okay, so with that we finish our discussion on cyclophosphamide or a video series on cyclophosphamide in pemphigus vulgaris. Sorry, cyclophosphamide in dermatology with its multiple indications, major indication being pemphigus vulgaris and the use of DCPs in pemphigus. I hope that after this discussion we are much more open to use of cyclophosphamide in various disorders. Apart from pemphigus, I have used cyclophosphamide one-day pulse to control an LE patient who had significant cutaneous involvement. But apart from that, I have seen multiple patients who have taken DCP and now living a relatively healthy life with good control of disease. So this becomes a very important drug that we must know of, so that if the indications is suffice and if the patient is agreeable to all the associated caveats of this drug, we can use cyclophosphamide somewhat safely and manage multiple skin disorders. If there are any other questions, any other clarifications, you can email me anytime on my email ID. If there are any doubts, any suggestions regarding presentations or any other queries, any questions that you have been asked regarding cyclophosphamide in your Viva and you don't know the answer, it's better to share the question so that we can search and everyone will become a bit wiser because of your doubts. Okay, so with that, I'll finish this video lecture and we'll have another drug to discuss next week. Okay, so bye.